Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 18th virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I am a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. We are recording this evening's presentation so that you can revisit it again. Please feel free to tell your family and friends about it so that they too can view it on either the IBJI or the NSYMCA websites. Tonight's program, entitled Knee Pain and Injuries, will be hosted by Dr. Gregory Portland. Knee pain is a common complaint that affects people of all ages. It is one of the most common body parts to be injured. Pain in the knee or knees can be caused by injuries, mechanical problems, different types of arthritis, and a host of other problems. And let's face it, getting around and doing everyday activities are harder when your knee hurts with every step you take. Tonight, Illinois Bone and Joint Institute's Gregory Portland, MD, will explain the many different signs, symptoms, and treatment options available when you are dealing with knee pain. Dr. Portland is a board-certified orthopedic surgeon with an additional certification in sports medicine and has been with Illinois Bone and Joint Institute for 20 years. After suffering through several injuries while playing collegiate-level sports, he received excellent orthopedic care and was able to return to play time and again. In seeing the pleasure his doctor took by being able to provide life-changing care, he decided to turn his focus from a business-related degree to a medical degree and thus became an orthopedist himself. Dr. Portland is proud of the fact that he's been able to treat entire families and even several generations within families to help his patients maintain healthy and active lifestyles. Dr. Portland sees his first role in providing care as educating patients to make sure they understand their condition and their treatment options. He believes well-educated patients are more likely to do what they need to do to help themselves get well. Dr. Portland is a clinical associate professor at the University of Chicago's Pritzker School of Medicine. He is the head team physician for Glenbrook North High School and previously has been a team physician for Northwestern University and a medical consultant for Major League Baseball and the National Football League. He specializes in arthroscopic shoulder and knee surgery, including repair of dislocated shoulders, injuries to the rotator cuff, shoulder tendons, and knee ligaments, as well as meniscus tears. Thank you again for joining us this evening, and thank you, Dr. Gregory Portland, for your time and effort in putting together this presentation to teach us about knee pain and injuries. Now, Doctor, please take it from here.
First off, I want to thank you, Karen, for inviting me to come in and present to everyone tonight. And most importantly, I'd like to extend my appreciation to everyone watching the webinar tonight and take some time out of a busy schedule to come and see this. Hopefully, we can make this interactive at the end. Hopefully, one of these days, COVID will end so we could see each other in person, but we'll accept what we can with the webinar. So as Karen stated, this is going to be focused on the knee, and as a treating doctor, especially when you cover sports of all ages, this image that we see here is when your heart drops to your shoes. One of the hard parts of being a doctor is that people get hurt. I wish I had a job where I was not busy, but that's not the case. And unfortunately, with the advent of more and more people working out, training, playing sports, the incidence of injuries to our knees continues to climb. The first thing I want to do tonight is just go over some basic anatomy, just from the standpoint of, as I discuss some of these case studies, what makes sense. So the first thing to know is that our knee is made up of bones. The bones are the steel girders of our body. They provide support. They also are the origin and the attachment of the muscles and the tendons. So for our knee, just going back once again, we have our thigh bone or our femur, our shin bone or our tibia, and the front bone is called the patella. And the patella is what we call a sesamoid bone. So it's kind of encompassed by the quadricep tendon as well as the patellar tendon. And those tendons help extend our knee. Ligaments, so the definition of a ligament, ligaments connect two bones together. And we have a whole slew of ligaments in our knee. The ones that I'll just mention, which are the most commonly mentioned, is the medial collateral ligament, or the MCL, that connects the thigh bone to the shin bone on the inner part of our knee. There's also the LCL, or lateral collateral ligament. That's a ligament on the outside part of our knee. Deep inside our knee is a ligament called the ACL, or anterior cruciate ligament. The role of that ligament is that it prevents anterior translation as well as rotation if our muscles don't fire fast and efficient enough. And then finally, in the back center part of our knee, we have a ligament called the PCL, or posterior cruciate ligament. And the job of that ligament is to prevent posterior translation of the shin bone relative to the femur. The next term which is important to know is our cartilage. So the knee cartilage is the white glistening stuff. So if you look at the picture to your right, that metal object is a shaver. But on top, that, believe it or not, is the end of the thigh bone. And coating the end of the thigh bone is our cartilage. So cartilage is a smooth, durable surface that caps the end of our bones at the joints. And it does two main things. So the first is that it provides a smooth gliding surface. I think all of us who are getting a little older can attest to that. When we were a 16-year-old, we really weren't aware of our joints moving at all. And now that I'm a little over 50, I wish I could say that I wasn't aware, but certain parts of my body let me know after a while that they're not quite as young as they used to be. And part of what happens with the cartilage is not only does it provide a smooth gliding surface, but it also shields the bone from stress. So if our cartilage thins out, or if we lose our cartilage entirely, what happens is the bone will swell. And actually, if we get MRIs of people who have arthritis, you actually can physically see fluid within the bone where it's swollen, and that fluid and that swelling equals pain. So arthritis just means loss of cartilage. So when someone, instead of having this white glistening surface, it is gone and we can see bone, by definition, that is arthritis. So there's another thing which is somewhere between normal and worn, and that's called chondromalacia. So chondromalacia just means some wear of the cartilage. Chondro meaning cartilage, malacia, bad or weak. So these terms get thrown around, they get very confusing. So just think there's normal cartilage, there's worn cartilage or chondromalacia, and then there's complete loss of cartilage, and that's arthritis. The next term, which to confuse people, a lot of times people will call this a torn cartilage, is we have a disc in our knee called the meniscus. So if you look at the picture on the right, the meniscus, we have one on the inside part of our knee and one on the outside part of our knee. And the meniscus is a C-shaped disc, and it's made of not cartilage like joint cartilage, but what we call fibrocartilage, or more kind of scar cartilage. So it's a very durable shock absorber that sits between the thigh bone and the shin bone. So the purpose of this meniscus is literally a shock absorber. So as we walk, as we jump, as we twist, a lot of that stress on our body goes through the meniscus, and it travels along the fibers and it dissipates the force. So what happens then is we have this meniscus, and it lets us be very active over time without developing pain. And one concern as the meniscus tears is that we lose more of that shock absorber, and just like a car, the knee is going to see more wear, the cartilage is going to wear faster. So therefore, the meniscus indirectly prevents arthritis. And as I said, we have a medial or inside meniscus, or a lateral and outside meniscus. Okay, so we're now going to go that we've gone over the terms. We're now going to do a couple of case studies, and hopefully this will kind of illustrate some of the points I hope to make tonight. So the first case is a 48-year-old male who presents 5 weeks of pain underneath their kneecap. And this individual enjoys running 4 days a week, and he does Stairmaster. So he comes in with pain. He has pain that's not incapacitating, and he really has no swelling and no treatment at all. So most likely what's going on is with orthopedics, a lot of times our anatomy dictates what's going on. So if someone has pain underneath the kneecap, the most common thing that this would be some worn cartilage under the kneecap or some patellar chondromalacia. So the kneecap runs along the front part of the thigh bone, and that's called the patellofemoral joint. So we use the kneecap, or there's the greatest stress on the kneecap when we run, when we go up and down stairs, when we squat, when we lunge, when we hike and we go up and down declines. Usually the kneecap does not give us pain with normal walking. So oftentimes if people have pain in the front part of the knee, one of the things that can help me decide where the pain is coming from is if they say, yeah, I have a lot of pain with going up and down stairs and squatting, but I have no pain with walking, it really pushes the possibility of the patellar chondromalacia being the cause of the pain. And those activities that increase stress on our knee, such as long runs or box jumps or going up and down heights such as hiking, often can irritate this. So this is a picture from a surgery. This is a surgery called an arthroscopy, where we make little holes in the knee and we insert a camera and we look at the joint. So normally our cartilage should be nice, white, silky, and smooth. So if you look here at the top part of the kneecap, that part is nice, smooth, glossy, white cartilage. But if you look kind of in the center part, and I'm trying to use my mouse, but unfortunately, I'm not really able to point with that. Kind of that undersurface of the kneecap there is pretty worn. And that's what we call chondromalacia. So there's still cartilage there, but because it's thinned out, when it sees more stress, that bone can swell and it can hurt. Well, what can we do? Well, we don't have a cure. So in 2021, we do not have any means medically, either with shots, pills, or surgeries, to completely resurface our joints with brand new cartilage. So as a result, all we can do for this is treat the symptoms. So, well, how do we achieve that? Well, the first thing that we can do is we can decrease the load on the kneecap. And one of the best ways we can do that is to improve our core power and flexibility. So one thing that can happen when we run, or one thing that can happen when we hike, is a lot of times we fatigue from our breathing, from our cardiovascular aspect. Usually if we stop running, it's because our breathing gets hard. But what we're not aware of is that as our muscles, especially our gluteal muscles or our butt muscles, fatigue, it changes the rotation of the femur. And as it changes that rotation, there's a lot more stress on the lining or the cartilage of the patella. And that stress will cause it to swell and give us pain. And there are a couple different ways you can work on that core power and flexibility. For the first thing, it's not a bad idea to see a therapist. They can identify where you're tight, where you're weak, what specific exercises you can do to transition to that. But for a long-term basis, I have not had great success with people saying, gee, I'm doing my sheets my therapist gave me 30 minutes 3 times a day. That's not really realistic. So oftentimes what I encourage people to do is transition from doing therapy to doing something that they're going to continue on a long-term basis. And a lot of the things that can improve a lot of our power and flexibility are things such as yoga or Pilates, or working in a class or with an individual trainer. Another thing that can be helpful for that initial flare-up are pills, Advil, Aleve. A lot of times if people are big runners, as they do a longer distance, sometimes it's not a bad idea to do a little Advil an hour before the run. As long as you stay well hydrated, it'll help you get through the run. It will help you recover. If people have significant pain where their pain just isn't calming down, a lot of times we can give them a shot of steroid. So the old school name for steroid, a lot of people will say, well, I want a cortisone shot. So cortisone was an older steroid. Nowadays we use a steroid that is much more specific for inflammation, and oftentimes that can really help people's pain and swelling to come down. We can't do shot after shot because the cartilage can deteriorate our cartilage, but a single shot often is acceptable. And then the final thing, which sometimes people aren't aware of, is that if people have flat feet, that foot striking the ground when we run, it will change the rotation of the femur. And like we talked about, that rotation of the femur can increase the stress on the kneecap and can lead to pain. All right, so the second case. Okay, so a 17-year-old female is playing soccer. She plants and twists her knee with immediate pain, pop, and ability to bear weight on the knee. She has significant swelling. So in medicine, we often will form little lists and say, okay, well, what could this be? So if you know anyone where this happens, and they don't have to be 17, where they twist, plant, feel a pop, get immediate swelling, the first thing is you should go and seek out an orthopedic surgeon. These typically are more worrisome injuries that we can see. And the list going from most to least common of this is one where someone's torn a ligament inside the knee called the ACL. A second thing could be where that individual may have torn the meniscus. A third thing that can happen is people might have dislocated the kneecap. And finally, sometimes it can indicate a break. And unfortunately, there are some injuries where I have seen where all four of these things happen simultaneously. So these are bad players, and therefore, if someone goes down, they shouldn't try and forget about it. They should seek orthopedic attention. So in this case, the most likely thing, as we said, is where someone tears a ligament called their ACL. So the ACL, we hear a lot about it with athletes. We hear a lot about it on TV. And the ACL, the job of the ACL is to prevent translation of the shin bone relative to the thigh bone. And in addition, it also helps control rotation. So what can happen is if our muscles don't fire rapid or efficient enough, a lot of that stress of a jump and land or twist will get transmitted to this ligament and it can tear. The ACL is not critical for life, but if someone has torn theirs, the knee may buckle, and this buckle can lead to a couple bad things. It can lead to loss of confidence, where we start to avoid activities. It can lead to tearing of the meniscus. And as we said, if that meniscus gets compromised, it can then indirectly lead to damage to the cartilage. And occasionally we can get such bad buckling that direct damage to the cartilage can occur as well. So if someone tears their ACL, well, what do we do? Well, a torn ACL unfortunately never heals. So there are really two options. So the first option is to rehab the knee and see if muscles can compensate for the tear. And the more aggressive that athlete is, the harder it is for rehab in isolation to control the loss of an ACL, where the knee will buckle and that person will lose confidence or do more damage to the knee. If someone is very low demand, I bike, I elliptical, I swim, then there's an excellent chance where rehab will work for that athlete. If people are really aggressive or younger or have some other damage where it may make sense to fix that at the same time, then we can surgically reconstruct the ACL. So the best medical treatment is have it never happen. So the question is, well, what can we do to not tear my ACL? Well, the biggest things I would impress upon you are, one, have your core power and flexibility as good as you can. A dynamic muscle is a strong muscle, okay? So these muscles are going to help stabilize you for those things where we can tear ACL, such as running, jumping, and landing. Make sure you warm up, make sure you stretch. There are programs that exist where they teach people and evaluate people on how to jump and land. Teenage females jump and land different than men. There also are ways where we can evaluate how people move. So there's dynamic functional movement screens and training. So these are all things that can help improve the way we move, and hopefully we will get hurt less. And then the biggest concern that I see a lot is in the world of 2021 is that tournaments will push adults and kids alike to fatigue. And as we fatigue, remember those muscles, if they don't fire fast enough, we can do damage to the ACL because that force gets transmitted. So beware of paddle tennis tournaments or soccer tournament for your child or any other tournaments, because if you think about it and you look at the best players in the world, well, how frequent do they play a game? Well, the US women's soccer team will play one soccer match every 3 games at the most frequent, and we're asking a growing 15-year-old female to play 3 games on a Saturday and 2 games on a Sunday, and we then wonder, gee, well, why did they get hurt? So just as I said, you know, my plea is just be careful with the tournaments. All right, moving forward, we now are on case 3. So we have a 55-year-old female who presents with 1 month of severe knee pain. So she twisted her knee playing tennis. She has pain with twisting, squatting, and sleeping. Occasionally her knee feels like it's getting stuck, and she does report that the majority of her pain is at the inside part of her knee. Well, most young men and women my age or in their early 50s, it's pretty common where people can develop some tearing of the meniscus and a little bit of mild arthritis. If you take 100 men and women age 50 walking down the street who do not have pain, at least 30% of people may have a torn meniscus in their knee and never know it. So one of the mysteries of my job is there are some people who may have a meniscus tear and don't have pain, and there may be someone they're standing next to who may have a very similar looking tear on MRI and they have terrible pain. So that's one of the mysteries. So one of the hard parts about this, as I said, is to get our heads around that if our knee becomes sore, there may be damage in there that's been developing for years. And it's not always the meniscus that hurts. We have to keep in mind that our knees wear faster than our minds. I don't know about you, but I feel like I'm 20 years old still. So as I said, it's very common for our cartilage to deteriorate silently. And oftentimes, as we start to develop pain, there can be significant cartilage wear when we first become aware of it. In addition, the same can happen to the meniscus, where over time it can continue to wear, and then often it can tear either with or without us being aware. So there are a couple different ways we can treat a torn meniscus. So the first treatment is to accept that there is a tear and eliminate pain. And the things that we can do to help that are using an anti-inflammatory such as Advil Aleve, trying a shot of steroid, and/or physical therapy. All 3 of these have a reasonable chance of helping pain related to a torn meniscus. Then the other option that we have is to surgically trim or suture the tear. And really what we do to determine which of those 2 things we do is based on our cartilage. So if our cartilage is deteriorated, where we've already developed arthritis, then the role of the meniscus really isn't needed anymore, because the job of the meniscus, as we stated, was to lessen the load and keep the articular cartilage or the joint cartilage from wearing. So if our cartilage is deteriorated, there is no role to suture the tear. And usually when people get to be late 40s and older, usually there's enough cartilage wear to where trying to stitch a meniscus doesn't make as much sense as when we're dealing with a 20-year-old. So I presented the treatment options for a meniscus tear. So how do we treat worn cartilage? And like I already stated, nothing exists to create new cartilage. So our options are to decrease inflammation, which can be an anti-inflammatory or a shot of steroid. We can decrease load. That can involve modifying our activity. Instead of running 5 days a week, I'm going to run 2 days a week. And then the other days I'm going to bike or I'm going to do elliptical. Weight loss can play a role. The heavier our load is on our knee, there's more stress on our knee. And there are a variety of different things we can do to lose weight. One program that my company has developed is a multidisciplinary program called Ortho Health, because one of the challenges as we age and our joints age is to try and find activity to keep our baseline metabolic rate elevated to where we can lose weight, and that often is difficult if we have painful joints. So another thing that we can do is to improve our mechanics to decrease the load. That's either with physical therapy or training. And occasionally we do surgery to smooth down the rough edges of worn cartilage. It's a less predictable surgery because even though we smooth down the edges, the cartilage is still worn. So here's basically an algorithm that I use a lot of times for people in their mid to late 40s and older if they present to see me with a torn meniscus and some mild arthritis. So if someone has knee pain and they have what we call mechanical symptoms where it feels like the knee's catching or locking, that typically is an indication where the meniscus is the cause of pain and surgery is warranted. If there's pain only and no mechanical symptoms, we usually will try the non-surgical things, activity modification, anti-inflammatory therapy, and steroid injection. And if it seems on MRI that they have more arthritis than a meniscus tear, we can do some gel injections, which I'll talk about shortly. If it seems like the meniscus is more the problem, then we can do a surgery to address that. So the surgical results of cleaning up a torn meniscus in a person 50 and older is not as predictable as some other surgeries that I do. Oftentimes, what I'll tell people who have some mild arthritis and a meniscus tear is that there's a 40% chance your pain is gone, another 40% chance your pain is significantly better, but certain activities you may have a little bit of soreness. There's a 19% chance you won't get better because it's more arthritis causing the pain, and there's a 1% chance you could be worse. Unfortunately, there's a small percentage of people, if we do surgery, where we blow that knee up with fluid to do the arthroscopy, where it can trigger arthritis in a bad way. And then there also is a small risk of a stress fracture developing. So here's a picture of a degenerative knee. So on the top of the screen, the white round area, that's the cartilage over the femur. The bottom of the screen, that's the cartilage overlying the tibia. There's a little bit of mild wet wear. The metal instrument is a little biter, and the far back part is a meniscus. So what this person has is they have a split in their meniscus, and then we kind of clip out the bottom part so that the top edge and the bottom edge don't rub against each other and cause pain. So this is kind of a picture from surgery. So this is a torn meniscus, and I'm just using a little instrument here to go ahead and just start to kind of bite this. And by removing the bottom part, then hopefully we can eliminate the pain from the meniscus where the pieces don't rub against each other and give us pain. And then after the little biter, we then have a little shaver we can then use where it kind of will suck in the torn little pieces. And then there's a little vacuum that will kind of suck the pieces in, and then it will kind of has a rotational blade that will just kind of clip the meniscus. And hopefully by getting rid of that under flap, that the top part will still provide protection to our knee, but will eliminate the pain from having a tear. And that's kind of more of a completed look at what the meniscus tear looks like. And I just want to point out for what normal cartilage looks like. So if you look to the right side of the femur, or the upper part, you can see that cartilage is nice, white, smooth, silky. And if you look at the left side of that same femur, you can see that where there's almost a little pothole. So that's some cartilage where it's almost all the way down to bone. So that's definitely some early arthritis of that knee. Here's what we do for worn cartilage. So we are looking at the inside part of a knee, inside part of a femur, the top part where the crab meat looking stuff, that is the cartilage wear. As we said, that should be smooth gliding. And then we use this metal shaver to go ahead and smooth it down. So here we go. So this is the camera looking at the femur. And we use this little shaver where it kind of sucks these little cartilage hangnails into the blade, and we then kind of smooth this worn cartilage down. And as we talked about, unfortunately, we cannot go ahead and plaster some new cartilage in there. All right, our final case of the night involves a 67-year-old gentleman who has been out on their feet, been working out, doing large amounts of yard work, and their knee just swelled up. And they have pain throughout the whole knee, especially at the inner part of the knee, and they're having difficulty walking. So they come to my office, I get an x-ray, and this is what the x-ray looks like. So the top bone is the thigh bone or the femur, the bottom bone is the shin bone. And what we can see on the left side of the screen there where the arrow is pointing is there is no black space. So as we stand, the black space represents the cartilage of our knee. So this gentleman has completely eliminated all the cartilage on the inside part of the knee. And like we talked about, that's arthritis. That's a definition of arthritis, where there's no arthritis or where there's no more cartilage left. So why does arthritis hurt? Well, if you look at the x-rays on the right, the person with the normal joint space, we can see the black space between the thigh bone up above and the shin bone down below. That black, the bones are coated by that black space, which is that cartilage. That white glistening stuff we just saw in the arthroscopy does not show up on x-ray. So that black space indicates they have normal cartilage. And then if we look at that x-ray on the far right, we can see that that black space is completely gone. And as that happens, the bones wear against the other bone. So as our bones lose the protective effect of the cartilage, the underlying bone swells and it can give us pain. And furthermore, as the bone swells, it can trigger a spastic healing response by the knee to form bone spurs that can lead to a loss of motion. So this is what arthritis looks like. So if you remember back to the picture where we had this nice silky, smooth white surface, if you look, you can see this yellow surface. So the yellow surface for this individual, that is the end bone of their femur. So as this person walks, the stress of their body goes through that joint, the bone sees the stress, it will swell and it will hurt. Remember, this is what a normal cartilage looks like at the top, that white, glistening, smooth surface. So what can we do to help arthritis pain? Well, because we can't cure it, we can just modify the symptoms. So the things that we can do to help arthritis pain are, one, take anti-inflammatories, whether it's in pill form, gel shot, or correction, topical gel or shot in a steroid form. The second thing we can do is we can inject the knee with something called viscosupplementation. This is something covered by insurance carriers where we inject the knee with building blocks of cartilage called high hyaluronic acid. It's more successful in mild than severe arthritis, but it can help people with arthritis. The third thing we can do is therapy. As we improve our mechanics, oftentimes that improved load sharing and motion can help people's pain. Weight reduction and load reduction through activity modification all can help arthritis pain. So once again, as we start to get arthritis, it's really critical to try and get as much mileage out of our joints and cross-train. Some days we jog, some days we bike, some days we swim. So the ultimate treatment, if people keep having pain despite everything I just mentioned, is we can proceed with a replacement. So for a knee replacement, we consider that when you've tried everything else and people have pain with walking, they have pain with sleeping, and they're avoiding activities. Oftentimes I'll see people that say, I don't want to do a knee replacement, but they won't walk more than a block with their spouse. And with a knee replacement, you can walk till you're blue in the face, you can play doubles tennis, you can ski, you can play golf, you can bike. So people can be active with a replacement. So my recommendation to my patients always is just make sure you're not avoiding reasonable activity. If you want to run marathons, no, I don't think a replacement makes a lot of sense. And then finally, the thing too that can happen is if people get too much of a bow-legged or knock-kneed appearance like we see here, sometimes we have to do a replacement because if we wait too long, the result could be compromised. So once again, a knee replacement is just an operation where you recoat the ends of the bone with metal and plastic. So if you look at the image on the right, typically the component on the femur is all metal, and then on the tibia, there's a metal base plate and a polyethylene liner. And by recapping the knee with this, it shields the bone from stress, and at the same time, spurs are removed to improve motion in that individual. So the last thing I want to touch on tonight is something called biologics. So over the last couple of years, there's been a lot of study and utilization of different things that have been injected in the knee, and we're not sure how impactful these will be with time. Despite a lot of the ads that we might see in the newspaper, none of these things grow normal cartilage. But what they may do is they may firm up the worn cartilage where it hurts less and wears less. It may change the local environment where pain is better. So as I said, we're still collecting data, the jury is still out, and the different kinds of shots can range from our own blood, it's something called platelet-rich plasma, or some amniotic fluid, or bone marrow. And once again, none of these things are covered by insurance. None of these things have completely firm success rates or failure rates that we're aware of. We're doing a number of studies. It's just not as well studied as a lot of other things that we would like. These are some ads that a lot of times we can see. I think there's a lot of misinformation out there. Knee injections are like putting a pillow in your knee joint. Well, not really. If you look at that upper right paragraph, this center uses X-ray machine or ultrasound machines for injections. What they don't tell you is that for every injection with ultrasound or X-ray, that there's an insurance bill that happens. For really good trained orthopedic surgeons, the accuracy rate of an injection in the knee is 92 to 93%. So for them to say that that there's a 70% chance that the gel's in the wrong spot, I would argue is a little disingenuous. If you look at the paragraph in the center, the truth is a knee replacement doesn't give you a new knee like many people think. In fact, only 5% of people get anything close to normal activity. I would argue that a lot of people can live an appropriate life for someone who gets their knee replaced. And I would say the likelihood where someone has chronic pain after a knee replacement, fortunately, is no greater than 10%. So I think, you know, we have to be really careful as far as what information is out there. Unfortunately, not all of it is reputable. I feel fortunate that orthopedics has pretty strict standards, and I think the majority of orthopedic surgeons are likely going to give you pretty accurate information. And if you're not sure if the information was correct, there absolutely is no harm in seeking out a second opinion. So the closest thing that I do for biologics is something called platelet-rich plasma. Why do I do this? It's the cheapest of these biologics. Unfortunately, it's more expensive than we would like, but this is the only treatment that is not 4 digits. All these are expensive. So what we do is we remove blood from the arm, we put it in a centrifuge, we remove the platelet-rich plasma layer, we inject it in the knee. Early results show improvement in pain, especially in people with mild arthritis. And if people get improvement, it can last between 6 to 12 months. For mild arthritis, a lot of studies have an improvement rate between 50 and 70%. For severe arthritis, it is not as effective. It does not regrow cartilage, but it may change the local cartilage or the local environment where people's pain is better. Unfortunately, we don't have any data to know, does this help me avoid a knee replacement? We don't have any data knowing, does it change whether arthritis progresses or not? Hopefully in a few years, we'll have that information. Bone marrow aspirate. Some of the studies so far seems like this might be a little bit more encouraging than the platelet-rich plasma. Unfortunately, it's quite costly. This ranges in the thousands of dollars. A lot of people, or some people, can have some pain related to their pelvis. Typically, the pelvis is harvested just like a bone marrow aspirate. and the jury is still out on how effective it is. So in conclusion, knee pain is common. Do your best to maintain good core power and flexibility. Make sure you do your best keeping your body weight as good as you can. Stretch before and after activity, cross-train, and most importantly, don't get hurt. So, just be smart about what you do. We all like to be flexible. We all like to do things, but as we age, we're not 13 years old anymore. So just be smart. And I really appreciate everyone's attention. Thanks for everything.
Thank you, Dr. Portland, for answering so many of the questions that came in already through your presentation. I've got a few more that I would like to address from different people. The first one is it best to go downstairs backward to reduce impact on the knees?
I don't think your neurologist will want you to do that. So I'm not really aware where that's a great thing to do. It would change the load, but I think for the other risks involved, I would not be a fan of that.
Great, thank you. And how about this from Anne? How do you know when outer knee pain how do you know when outer knee pain going upstairs is the IT band versus a ligament issue?
With pain with stairs, usually that's not going to be a ligament issue. So the short list of what that could be is it could be the iliotibial band. It could be worn cartilage either on the patella or on the outer part of the thigh bone called the trochlea, or it could be a meniscus tear or some worn cartilage on the outside part. The fourth thing it occasionally can be too is sometimes it can be pain related to our hip, where we have a bursitis in our hip, but we feel it on our knee. So Anne, I would put my bet that the cause of pain is one of those four things.
Great, thank you. And Selena asks, is there a complex lateral meniscus, if there is a complex lateral meniscus tear shown on an MRI, but no visible loose parts nor fraying, is an arthroscopy needed? And if so, what gets done during an arthroscopy procedure? So you covered this topic, but thought the question might be a little bit, give a little bit more information for people.
Yeah, so the first thing I would say is, are there symptoms? Is there pain and is there mechanical symptoms? So if someone has this tear and does not have symptoms, usually we would just observe it because we can't do better than no symptoms. If people have symptoms, then a lot of it boils down to the age and the articular cartilage status of the knee. So if the cartilage is normal, we're much more aggressive trying to stitch that and try and get it to heal. If the knee is getting worn, then usually we will trim it. One of the challenges if we fix a meniscus is the healing rate is only 70%, which means there's a 30% chance it could re-tear. And the other challenge if we fix a meniscus is the recovery is about 6 months, because we may put these stitches in, but the way our body heals, it's like Elmer's glue. It only heals at a certain rate, which is not as fast as we like, and if we stress it too much, it can re-tear.
Gotcha. Okay, thank you. Bill asks, what is your opinion on using a medicine such as Voltaren for arthritis pain relief, especially now that it is available over the counter?
Well, there's two types of Voltaren, so I'll address them individually. So the first is gel. So the Voltaren gel usually is going to be pretty well tolerated. A small percent of my patients get some irritation of the skin, but because that's absorbed locally, that's going to have the least side effects to your body. So if the gel does the trick, that would be the best bang for the buck. If we find where the pills work much better for us, then it's absolutely fine to take pills. I do recommend every 3 to 6 months where people get blood work to evaluate their kidney and liver function if they find where they need to take it on a more regular basis. If people have to take it more on a regular basis, oftentimes I'll consider pursuing some of those shots to see if we can help their pain so that they don't have to take pills quite as frequently. So a lot of medicine is finding that sweet spot where we can help symptoms but minimize risk with the treatments. But as I said, if we take it long term, there's a lot of people that do it, but I just recommend getting blood work and making sure you eat food with it so it doesn't upset your stomach. Because one of the big complications is either we can get a GI upset or even worse, a bleed or some kidney issues related to chronic anti-inflammatory use.
Got it. Thank you. People asked, what is the name of the new steroid? You mentioned that.
Yeah, there's two. So the main one I use is called Kenalog. So Kenalog is much more specific. So one of the concerns of the older steroids is not only can you get anti-inflammatory properties, but does it cause some of the other things? Do we bloat? Does it impact my my adrenal function? And so as a result, fortunately, they've developed one that is much more sensitive for just being a pure anti-inflammatory.
Okay, got it. Thank you. All right, Rose asks, when taking my 2 to 3 mile walk, turning my foot out helps the pain. Any idea why?
Most likely you have a little cartilage wear, and that change in your rotation makes you unload the stress where you're not loading the worn part quite as much. That would be my guess.
And kind of like you were talking about in changing things that you can actually reduce the pain just by doing a gait change like that.
A gait change, or even if you have flat feet, a shoe with a cushion insert, like very subtle things sometimes can give us significant relief.
Great, thank you. And that includes, like you were talking about, the core strength, especially the gluteal strength. If you can strengthen, you might even change your gait and not even realize you've changed your gait.
Correct, exactly.
Okay, great, thank you. Wendy asks, once diagnosed with arthritis, how can I help with the feeling of instability?
Well, I think it's a multimodal approach. The first thing is you maintain your core power as good as you can. The second is you keep your body weight as good as you can, so there's a less pull of gravity. And then the third is pain can inhibit our muscles firing. So we just want to make sure that our muscles are strong and firing. The biggest thing, Wendy, that I would say is just make sure you get your knee evaluated. Sometimes we can have loose chips on our knee called a loose body, or sometimes we can have some meniscus tears with flaps, and those can give you a sense of instability. And you can take all the pills, all the shots, do all the therapy, and unfortunately that instability feeling will be there unless they're addressed. So most of the time those initial things can help, but there are a couple conditions where if they're going on, then sometimes the best treatment is just to remove a loose chip if that's the cause.
Gotcha. Okay, thank you. All right, this one's a little bit personal for you. I hope you don't mind. It says, hi, Greg, this is Robin Sanders. Yes, that Robin Sanders. My question is, where does chondrocyte transplantation / implementation have a role, or is that concept now passé? And she says, great presentation, so good to see and hear you.
Robin, thanks for staying away. It's great to hear you. It's not personal. I hope to see you on the street. So anyway, usually for chondrocyte transplantation, there still is a role for it. And basically what a chondrocyte transplantation is if someone has some damage to the cartilage and literally a pothole. So we have normal cartilage with a focal area of completely damaged cartilage. Typically what we do that is in a population 40 and under, because if we start to get a little arthritic, then there are more enzymes in our knee that will just make the cartilage transplant fail. So usually it's individuals 40 and under with normal cartilage other than that area with a certain body weight. So the contraindications are too old, too much diffuse cartilage damage, or too much of the cartilage throughout the whole knee is damaged, and too heavy.
Okay, thank you. Thank you. Marnie asks, what is your opinion of COOLIEF, COOLIEF treatments?
Yeah, that's not Main Street for orthopedic literature, so I can't really comment on that, so I'm sorry.
Okay. Oh, great. That's okay. I didn't know what it was either. So thank you. Let's see. Please go over anti-inflammatory gel versus viroelastic gel from
So
Bruce.
yeah, so the anti-inflammatory gel is topical. So it's a tube of anti-inflammatory called Voltaren. If you go to Europe, there's ibuprofen gel, so you just squirt it on your hand, you rub it in. So if people say I'm going for a gel shot, what they're referring to is that shot called viscosupplementation. So what it is, it's hyaluronic acid, which is one of the two main building blocks of cartilage. And there's about 8 different competitors that we use. Some of the names include Synvisc, Euflexa, Orthovisc. I'm blanking on the other 10,000 Monovisc, some kind of visc. So anyways, and then those are where we inject the hyaluronic acid into the knee. And we think it does 2 things. One is it kind of changes the local environment. And the other thing we think it does is maybe fill in some of the potholes where there's some worn cartilage, and over time it just kind of wears off. But once again, it doesn't grow new cartilage. And some of those full page ads that people are promoting in the Sun Times, like they're saying, yeah, it's new cartilage. No, it's not new cartilage. It's building blocks of cartilage, but it's not putting new cartilage in there.
Great, great. And how long do the shots usually last, asks Margaret, and can you get multiple shots over time?
So of the 2 main, well, we'll even include PRP into this, okay? So for steroid, usually for steroid, we want to be really cautious if the knee is not in bad shape, because if we do too many steroid shots, that can be hard on the cartilage and it can cause it to deteriorate. So usually a single shot is acceptable risk, but shot after shot isn't great. For people who have arthritis, the length of duration of a shot helping is all over the map. There are some people who get 2 months of relief. There's some who get 2 weeks of relief. There's some who get 2 years of relief. It's very individual. And even for people who respond, shot to shot is very different. From a gel standpoint, meaning the hyaluronic acid, that can be repeated every 6 months. So for Medicare, for the commercial insurance carriers, they typically will approve that every 6 months. And for people who respond often, it can last between 3 and 12 months. And I would say the majority who respond, it lasts 6 to 9 months. The PRP, because it's a cost out of pocket, it basically boils down to how much money do I want to spend? And then, you know, how much relief did I get? So I have some people, I think I'm on 5 years of PRP shots, and I have some others who tried it and were like, yeah, it didn't give me the relief I was hoping. So that's why I have gray hair. I wish I could make everyone perfect.
Yes, yes, thank you. Jim asks, what are your thoughts on glucosamine?
Yeah, so glucosamine is probably the most studied vitamin supplement out there. So glucosamine is also a building block of cartilage. And most formulations include glucosamine and chondroitin sulfate. It seems like those vitamins are a little better than placebo. So if you take sugar pills for a fifth of people, they say my knee feels better. So instead of a fifth, it's like 25%, it's a quarter. So if people want to try it, what I recommend to them is try it for a month. If you feel better, great, keep taking it. If it doesn't seem like it does much, then it's okay, you can stop. The one thing to be careful of with glucosamine and chondroitin sulfate is a small percentage of people, it can elevate their cholesterol or triglycerides. So if you go for your physical and your doctor wants you to go on, you know, a statin for your cholesterol, and you've recently added in some glucosamine, just FYI, you might want to tell your internist, let me come off of this for a month and take another blood test before I go on the medicine.
Thank you. Thank you. That's great. All right, I got a couple more for you. Steve says, I think you mentioned you can wait too long before getting a replacement that will make the replacement of your knee less effective. Can you clarify at what point this can happen?
Yeah, so that can happen if we have significant bone loss. So the platform where we put the metal and the plastic on the knee, it has to be nice and solid. So if it deteriorates too much, then that can compromise the type of replacement. So usually what I recommend is if people see someone with arthritis and they're doing okay and they want to hold off on a replacement, it's a good idea just to ask your joint surgeon, is there any concern? Do I need to come in on an annual basis? So if I have people who are gritting and bearing it, doing okay, and they have a lot of bone loss that I'm concerned about, a lot of times I'll have them see my joint partners for them to say, do I think they need to do a replacement sooner or later? I don't do the replacements, but my partners do. And then oftentimes what my partners will do is they'll have them get an x-ray once a year just to make sure they're not reaching that point of no return.
Got it. That's very helpful. Thank you.
I would say it's probably under 5% of people with arthritis. The majority of people can wait until the time is right for them to get it replaced. Great.
Thank you. Thank you. And one last thing about replacements. Michelle asks, why are blood clots so common with knee replacements?
So anytime you damage part of our body, that part of the body is at higher risk of developing a blood clot. So if I pull my calf muscle, I'm at a higher risk of developing a blood clot. So with a knee replacement, because you're removing the ends of the bone, that's more traumatic. The other thing is the normal muscle flow has been compromised. And then the third thing is a lot of times they'll use what's called a tourniquet. And a tourniquet will just keep the blood from going to the leg. So those are the three big risk factors that can lead to blood clots.
Gotcha. Thank you very much. All right, and the last question is, can you talk about OrthoHealth, the IBJI OrthoHealth program, and is it covered under insurance?
Yeah, so with the OrthoHealth, what it is, it's just a multidisciplinary program. So basically what it is, it's PT. So the therapist basically will take people and they have different machines to measure our metabolic rate, and they'll do different types of exercise to see what exercise works the best. Then there's a physician who quarterbacks everything. So they'll review everything from your diet to your meds to your activity level. There's a nutritionist. So it's a couple different prongs. The therapy visit is covered, by insurance. A lot of times the doctor's visit is covered. Some of the nutritionist I think is less likely covered, but I think the majority can be covered. So what I would, for anyone remotely interested in that, you can just go to the IBJI website. There's a contact person who can get more into the nitty gritty of that, and could help you with your benefits and determine, is it all covered or partially covered, and what the obligation would be. But anecdotally, I would say patients of mine who've done it, I would say 60 to 70% are quite happy with good long-lasting results, which for weight loss things are actually pretty good. The other key component of it is sleep. Sleep and stress play an enormous role as far as weight. So, that's part of the discussion with the physician as well.
Terrific. All right, Dr. Portland, thank you so much for all of the great information that you covered and that you answered all of these questions that people had. I know there were a number more questions out there, but I did promise you I would let you go at 8 o'clock. So thank you very much, Dr. Portland. Thank you everyone for joining us this evening. Have a great night and stay healthy.
Thanks, everyone.